So hi guys, this is Dr. Harshavardhini again here. This is a video I'm doing to discuss about how we can use echo in the as a aid for checking or examining fluid responsiveness. So this is a continuation of my last video, fluid responsiveness. So, just a small brief. In my last video, I've discussed about Frank-Starling curve, how we have the few people who respond to preload responders and preload non-responders. In simple terms, what I can tell you is, for example, if a patient who's coming with acute pancreatitis or with a DKA, to begin with, on day one of symptoms or day one of admission, you're the first hospital they have reached into. You're the first physician managing the patient. The patient will be frankly hypovolemic. That is not the time to check for fluid responsiveness. Patient is frankly hypovolemic. You should resuscitate the patient for the hypovolemia. And then you have a patient who has right heart failure, who's come to with pulmonary edema and or a sepsis with heart failure, who is having pulmonary edema. In those patients is when you need to assess whether there is scope for fluid resuscitation. There's another set of patients with poor LV, CKD, where there's absolute contraindication. Probably I won't be able to give fluid, but in them also the dictum is to assess fluid responsiveness. Okay. Echo, it can be used to manage the response to fluid resuscitation. You have various direct and indirect measures to guide our therapy. It is easily available, non-invasive bedside assessment tool. It can be repeated at regular intervals, and this actually is a good thing as well as it is a flaw where I can't have a real-time guide or data like how we get in our cardiac output monitors. It's very subjective. What I see, what I assess might not be repetitive when another person repeats it. So, the static parameters, what we can assess is LV end diastolic volume and LV end diastolic pressure. The fastest way to evaluate the volume status of the cardiac chambers is obtained by visual evaluation, just by your looking at your LV, the way your LV is contracting, we can assess the LV end diastolic volume. In case of severe hypovolemia, you can see a kissing papillary muscle sign in systole, where both the walls will be coming close to each other. It's the best measured at end diastole. The volume indices are LV end diastolic area of less than 10 square centimeters, suggests significant hypovolemia. Pressure indices is the filling pressure which can be assessed across the LV indirectly by measuring the pressure across your mitral valve. That is E by A and E by E prime. So, this is the LV end diastolic area. If it is less than 10 centimeter, there is a possibility of severe hypovolemia. This is a normal LV and this is a kissing LV. As you can see, there's barely any cavity space. This is a kissing LV where the papillary muscles are in close proximity to each other. Estimating the pressure. For estimation of the pressure, you keep your pulse wave you keep your Doppler across the flow of your mitral valve. Maximum flow, where there is maximum flow area in your four chamber view, you keep your Doppler and you get this waveforms where the first tall positive wave we hear is called the E wave and the next wave is the A wave. E wave is nothing but the early diastole which happens. A wave is the after diastole which happens. When you put across the tissue Doppler, either you can use the medial or the lateral side of the annular attachment of your mitral valve. You get the positive wave as E prime. So the ratios what you can measure is E by A and E by E prime, where you will get to know if there is any diastolic dysfunction. Area has no specific cutoff. It's an approximate measure. As I told you, the dimension of the cavity can influence the preload, but not necessarily convert it into a stroke volume or cardiac output. Like DCM and hypertrophic cardiomyopathy, restricted cardiac diseases, this adequate volume or those cannot be translated into increase in your stroke volume and cardiac output. And then you have LV end diastolic pressure. The pressures can be altered with the alteration in your LV compliance. That is, if there is AF, it is not a reliable measure. If you're having restrictive cardiac diseases, it's not a reliable measure. MSMR, it's not a reliable measure. The LV can be easily underfilled or overfilled with elevated pressures, like in LVH and your patients with mitral stenosis and all. Coming to the dynamic indices, you have the LV outflow variation. That is, like, how do we estimate that? This is nothing but calculating your cardiac output using your stroke volume. First, you estimate your stroke volume and then you multiply it by the heart rate to get your cardiac output. How can I get a stroke volume? As we all know, the aorta, consider the aorta to be a tube. So you are going to measure the flow through the tube. How will I measure that? It is measured as velocity into the cross sectional area at a constant flow. We know that. So, but the blood flow is pulsatile. That is volume per contraction to be used. When you're putting the per contraction, you're putting a time factor. So we measure the velocity time integral. That is measurement of all the velocities of your RBCs at every contraction at a certain point. So you're going to catch hold of one RBC which is flowing across at one point and at one time. Okay. Stroke distance is nothing but how far the blood column is ejected in centimeters. So how do we put this all together? Volume is area into length. So here it will be area into velocity into time. That length is your stroke distance. Using a pulse wave Doppler, speed into time is your distance, right? So velocity into time. Using your pulse wave Doppler, stroke distance is nothing but your velocity time integral. How do you measure the area? Cross-sectionally, it's a circle. So it will be pi r square. The LVOT diameter the whole square. Okay. So velocity time integral into pi r square. So we get the stroke volume. And therefore, the stroke volume variation of more than 12% can accurately predict fluid responsiveness. More than 14% has very high positive predictive value. Less than 10% has very high negative predictive value. So, how do I clinically implement this? You do a challenge for the patient. Either you can use the PLR or you can directly administer the fluid while measuring this stroke volume variation. Okay. So when the variation is more than 14%, definitively your patient is a fluid responder. If the variation is less than 10%, definitively fluid is no more advised in this patient. As I told you, first you get the cardiac LVOT diameter. What is this phase? This is your phase of systole, maximum systole. You measure just a few centimeters above this, the maximum diameter. So the LVOT cross-sectional area here is 3.3 square centimeters. And then you have your velocity time integral, where you measure the velocity time integral in your apical 5-chamber view. You keep the sampling area as parallel as possible to the blood flow. And once this is measured, you calculate the LVOT VTI. So the LVOT VTI here you can see is approximately 19 centimeters. So your stroke volume is 3.3 square centimeters into 19 centimeters. And your cardiac output is, this patient is having a heart rate of about 92 beat per minute, 5.8 liters per minute. Okay. This is the way we derive the equation. This is a tubular structure and the area of this tubular structure and the flow across this tubular structure. Coming to the great veins. The assessment of IVC using a transthoracic echo is very conventional element of your echocardiography in any of our critical care patients. The variation of the transpulmonary pressure is transmitted to the right heart cavities, varying the vessel diameter and the venous return of the heart. This depends on the mode of ventilation as well as the compliance of your IVC. So, with the respiratory effort, when there is respiratory effort, there is negative transpulmonary pressure at the beginning of inspiration. Thereby, it induces a variable degree of IVC collapses. In a non-intubated patient, the tendency is the IVC will collapse because it's a negative pressure. Whereas in positive pressure, the IVC distends. So you have IVC collapsibility index and IVC distensibility index. IVC diameter, if you are just measuring the IVC diameter, that is whether it's less than 2 centimeters, more than 2 centimeters, at a single point, it will act as your static parameter. If the diameter is less than 10 mm or 1 centimeter, it is poor volume status. Similarly, if it is more than 2.5 centimeters, patient is in congestion or severe hypervolemia. This can be indirectly translated into your right atrial pressures. So, more than if you use the same thing, diameter and collapsibility put together, less than 2 centimeters with more than 50% collapsibility, somewhere your RP can be told to be 0 to 5 mmHg. More than 2 centimeters and less than 50%, your RP can be 10 to 20 mm of Hg. How do we assess? We use the subcostal view. As you can see, this is your aortic opening, this is your IVC opening. Your pointer is towards your right of the patient. Once you are getting a good view of the liver and your contractile heart, you rotate the probe such a way that your pointer is towards the sternum. Now your IVC is oriented this way. Okay. So how do we check? You go to the hepatic confluence. About this is your this is how your view will be. So this is the confluence of the hepatic vein with your IVC. You go behind this up to like about a centimeter, and this is where you measure your IVC. Okay. IVC is measured, diameter is measured at the end of inspiration and at the end of expiration. So end of inspiration is your maximum diameter, end of expiration is your minimum diameter. And then you calculate your distensibility index. In controlled mode of ventilation with a tidal volume of more than 8 ml per kg, you can have a distensibility index where your maximum minus minimum by the average of it, that is called the index, it will be more than 12%, or if you're using the minimum diameter, more than 18% is the cutoff. See, the pitfalls in this is you can have the variation in your intrathoracic pressure, which can influence the diameter. Variation in your right atrial pressure can influence the diameter, and your IVC compliance itself can influence your results. So, variation in intrathoracic pressure could be when there is low tidal volume, high PEEP, spontaneous respiration. When there is right atrial pressure, where your alteration increase in your right atrial pressure, that is cardiac tamponade, tricuspid regurgitation, RV dysfunction. IVC compliance, raised intra-abdominal pressure, thrombosis, compression, ECMO, all of this can affect your compliance. So, in these conditions, the results might not be reliable. Now, to overcome the influence of your intrathoracic cavity pressures, the SVC was used. A recent studies demonstrated that 67% of airway pressure changes during mechanical inspiration are transmitted to the pleura. Only 33% is transmitted to the pericardium and your SVC. So, from the anatomical point of view, the SVC has a proximal extrapericardial section and a distal intrapericardial section. Half of your SVC lies within the pericardium and half lies outside, when compared to the IVC, where most of it is outside. So this is the PLR examination where you can the cardiac output. See, PLR, one is you're giving the challenge. Next component of the test is you're assessing the results. What is the result you want to know? Whether there was change in your cardiac output. You can measure the cardiac output. You can measure your velocity time integral. You can use PLR to measure your pulse pressure variation or your stroke volume variation as well. In short, how do we do this? You begin with the patient in recumbent position. Once in that, you measure whatever parameter you have chosen. I would like to choose VTI. So I do a echo, I get the VTI. Next, after this should be an automatic bed where the leg end of the patient is elevated. Simultaneously, the upper torso lies back to the supine position. At this point, after a gap of 30 seconds to 40 seconds, I would like to remeasure my VTI. Again, after a minute, by the end of 1 minute, I put the patient back into the same position where again I measure the cardiac output or the VTI or whatever surrogate I've used. So, based on the results, if my VTI variation is more than 12%, yes, I'm confident to give fluid in my patient. Okay. Now, what is the benefits of doing PLR or what is the benefits of doing PLR? The benefits of doing PLR is for us to have ideal dynamic indices, that is your stroke volume or pulse pressure variation and all. They give you values. These are machine calculated values which you can see in your monitor. These values are ideal only when your patient has no spontaneous respiration, there is no arrhythmia, there is no lung compliance problem. Not always we have such patients. So, how do I assess when these things are not feasible? How do I assess? Obviously, if there is a patient with AF, I want to know if the hypovolemia is there. If the patient is manifesting shock, should I give fluids as while I'm treating the AF? Is there a scope for me to give fluids for the shock what I'm seeing? In our ARDS patient, what do I use? So, to overcome these barriers, PLR is advised because in PLR, it has no issues with your arrhythmia. It has no, you're technically using the man's physiology. So, it has no issue with patient having spontaneous breath. Also, there is no issue if your patient is having a low compliant lung, like in ARDS. But yes, there are contraindications for your PLR as well. The contraindications for your PLR is raised intra-abdominal pressure. Yes, you can't do it. Pregnancy, you can't do it. Uh, these are the two main, like post-surgical abdominal surgeries, you can't do it. Okay. Head injury, you can't do it. Now, how many times have we tried to get a good IVC view but failed? That is many times. So they try to assess the other surrogate vessels to help us get an accurate assessment. So the same thing for your LVOT VTI, they used carotid velocity time integral as a surrogate. Like that, in place of inferior vena cava, they used femoral vein as a surrogate. But the results were not very reliable. This studies are still being conducted in this perspective to make it because of the to overcome the barriers what we face in our day-to-day ICU practice. Okay. So this is how carotid VTI was used. And this is your femoral vein, which was IJV was used as well as femoral vein was used. Okay. Finally, to complement all of these findings, the lung scan can help you decide whether you have scope for fluid. That is, presence of B lines might preclude the need for fluids. As we all know, in critical care, this is not exclusively pulmonary edema. There are many more reasons for this. So you should take this with a pinch of salt because early ARDS might be setting in. So necessarily the B lines could be because of some other reason rather than your fluid overload. And sometimes it might even help you guide decongest the patient. Like in ARDS, more prefer to have a neutral negative balance rather than a positive balance. Okay. So I hope you all like this video and this was useful. Please kindly like, share, and subscribe to our AdviRush EM. We are conducting a comprehensive emergency program where we have various modules which we are using to teach the emergency pursuing emergency practitioners, that is our emergency residents, to help cope up with our DNB MD emergency exams, and we are trying to cover most of the emergency exams at least available for Indian students. Thank you so much.